So now I'm switching to the presentation. I'll start off with some basic observations around trends. So, of course, as you all will know, we're seeing increasing demands for health data for secondary purposes. These demands are quite varied in terms of what the data would be used for. In some cases, it's for research. Researchers are requesting increasingly access to the electronic health information that's being generated as we're digitizing health data in both Canada and the US and other jurisdictions. But also these demands are coming from public health. We do a lot of work with public health professionals who have been asking for more access to more data and linking more varied databases. And of course, there are commercial uses for the data as well, for the purposes of sales and marketing, but also for non-academic research. And for improving operations and finding efficiencies in operations from an insurability perspective and so on. What we're also seeing are stronger enforcement of the regulations with increasingly severe penalties. This is particularly evident in the U.S. With the fines from OCR and also the 150 audits that OCR has commissioned this year. In general, we're seeing increasing enforcement across the board in multiple jurisdictions. And of course, this creates a strong incentive to implement the regulations in a defensible way. In terms of what this data is being or would be used for, this is a slide from a report by PwC, and I think it really summarizes well how we're migrating in terms of data use over time from focusing on quality improvement and quality monitoring to kind of future world where health information will be used for many different purposes, including fraud detection, treatment efficacy studies, monitoring patient compliance, public health purposes, and of course marketing and sales opportunities. And this is based on surveys that PwC has done, but it's also very consistent with our anecdotal observations in terms of what health information is being used for in a secondary sense, for secondary purposes. So I'll start off by just covering a couple of basic things, some definitions, and making some important distinctions which are very relevant when interpreting the identification standards in HIPAA. And the first important distinction we'll make is between the different types of variables in a data set. This is a very traditional, uncommonly used distinction, but I think also it's a very important one. So if we have a database, we'll make a distinction between three types of variables. We'll call them the directly identifying variables, which are those variables that can uniquely identify an individual, such as the name and the email address, for example. And then you have the quasi-identifiers, or also known as the indirectly identifying variables. And these can probabilistically identify individuals as well by themselves or when combined with other pieces of information. The distinction between directly identifying and quasi-identifiers is gray and fuzzy, and to some extent it's context dependent, but it's still an important distinction because the way you handle the data from an identifiability perspective will depend on how you make this classification. And then you have the sensitive variables, which are most often clinical variables that are not very useful for re-identification purposes. And again, there's a gray area between when a variable is a sensitive variable and when it's a quasi-identifier. It really depends on the attack scenarios you're willing to assume, but the distinction is important. So from an identifiability perspective, we care about the first two. We care about the directly identifying variables and the indirectly identifying variables, or the quasi-identifiers. So examples of direct identifiers are name, address, telephone number, fax number, MRN, medical record number, health card number, health card insurance number, health plan beneficiary number, license plate number, email address, photographs, biometrics, social security number or social insurance numbers, and even implanted device numbers. And these are the commonly understood definitions of what a direct identifier is. Quasi-identifiers include variables like, well, the list that you see there, essentially the demographics, all kinds of dates, all kinds of geographic information, and socioeconomic status information, as well as diagnosis codes, procedure codes, adverse event codes. And the reason all of these variables can potentially be used for re-identification is these are things that are knowable. They're knowable by neighbors, by coworkers, by relatives, and they're knowable for famous people. They're not all knowable for everybody, of course, but these are the things that you'd want to consider when deciding whether a variable is a quasi-identifier or not. And some of them may not be obvious. For example, why is birth weight a quasi-identifier? Well, it turns out that does the first thing that new parents do when they have a baby is that they post on Facebook the weight of the baby. We had a baby, it's a boy, and he is X pounds. So this is information that individuals are increasingly sharing publicly as well. So all this information, because it's knowable, can potentially be used for re-identification, so we put them under the label of quasi-identifiers. Okay, so a second important distinction we need to make is between attribute and identity disclosure. These are two different ways that the disclosure control community has conceptualized disclosure, or individuals being re-identified. One is attribute disclosure, which when you discover something new about an individual in the database without knowing which record belongs to that individual. So I know that you're in the database, and because you're in that database, I know that you have condition X, for example. But I don't necessarily know which record in that database belongs to you. Identity disclosure, on the other hand, requires the adversary to know which record belongs to the individual. So if I know that record number 7 belongs to Bob Smith, then that's an identity disclosure of Bob Smith, because I know which record belongs to them, and therefore all the information associated with record number 7 becomes known to me about Bob Smith. So this is an important distinction. In most cases, we're concerned with identity disclosure rather than attribute disclosure. So I'll give you a simple example here. This is a realistic example, and it's about HPV vaccination. And there are some religious groups who do not vaccinate their daughters against HPV or give them the HPV vaccination for various reasons. One of them is they don't believe that their daughters are going to be sexually active during their teenage years, and therefore they refuse to vaccinate them. So imagine a data set where here we have a 2x2 table, and we have members of religion A and not religion A, which are the rows, and then HPV vaccinated or not HPV vaccinated are the columns. And in this case, we have 90 records in the database. So if you look at the first row, we see that all of those who follow religion A, the vast majority of those who follow religion A have not vaccinated their daughters against HPV. And there's very little heterogeneity in this row. So we can conclude with high confidence or high reliability that those in religion A have not vaccinated their daughters. So this is an example of attribute disclosure. That if I know that you are a member of religion A, then I can draw the conclusion about your decision to vaccinate or not to vaccinate. I discover this information about you without knowing which record in the database belongs to you, right? And the reason this occurs is because there's essentially homogeneity among all religion A members with regards to their HPV vaccination status. So because of this homogeneity, we learn something new about individuals who are in the database. So this is an example of a kind of a high-risk database or a table with a high risk of attribute disclosure. Now, a common way to deal with attribute disclosure is to remove or suppress the values on one or two of those variables, the vaccination variable or the religion variable. So for the sake of example, let's say we do the suppression and we end up here with this table, and now we've lost the relationship. The relationship that existed before between religion and vaccination, which was very strong, has completely disappeared when we do the suppression to deal or address the attribute disclosure issue. Okay? Now the problem here, of course, is that, as this example illustrates, attribute disclosure is an important part of the analytics on the database. If we want to do analysis on a database, we want to discover these relationships. One can come up with more complex or sophisticated examples where you have multivariate models and you want to use those to predict some relationships in the data. And if you try to eliminate these relationships, then the analytic utility in the data disappears relatively quickly. So that's one of the problems with attribute disclosure, is that it reflects the outcome, the analytic outcome that we want from the database. And so there's a question really about whether we want to eliminate attribute disclosure. One can argue that attribute disclosure is a function of ethics, whether the analyst, let's say it's a researcher, whether the researcher should be permitted to, whether there are ethical or public norms or other arguments that can be made to say that maybe certain research questions are unethical or unsuitable or should be done in a different way rather than being a privacy problem. So in this case, we'll say, well, you should not study the relationship between religion and HPV vaccination because it may cause various types of ethical dilemmas. So that's a completely different question, a completely separate issue. It's independent of a privacy issue or disclosure control issue, and maybe that's a better way to think about this rather than a privacy issue and as an ethical question. The other consideration is that HIPAA doesn't really talk about attribute disclosure. So the reason I'm bringing this up is some folks in the community have brought up the point that we should protect against attribute disclosure when we're disclosing data and so on. Apart from the first point about whether it's a privacy or ethics question and the data utility issue, HIPAA doesn't address this. It does not talk about protecting the discovery of information about specified groups in the data as an issue that needs to be considered when de-identifying data. So it's really outside the scope because of the regulations, but also because of the utility and ethics versus privacy question. But it's important to understand the distinction, and that from a HIPAA perspective, we really are focusing on identity disclosure only. So that means assigning a record to an individual, a record in the database, giving it back an identity. The other important point is that all rate identification attacks that are known, so all publicly known rate identification attacks, are identity disclosure attacks. It doesn't mean attribute disclosure doesn't happen, because, like I said, if you learn something new from the database, then it's essentially an attribute disclosure. But all publicly known and acknowledged rate identification attacks are essentially identity disclosure attacks. Okay, another important point to make is the distinction between tables and records. We see a lot of organizations that say we're only releasing tables, we're only releasing aggregate information in the form of tables and tabular data releases, etc. So if you're releasing a table of counts or frequencies, it's essentially an individual level data set. There's no difference between them. You can convert from one to the other. So whether it's an aggregate table of counts or an individual level record set, it's really the same issue. The fact that it's presented as a table doesn't make it okay just because it's represented at a table. Tabular data representation also raises a number of additional concerns which need to be addressed. One is that if you release a table and you suppress cells in the table, if you keep the marginal totals in the table, it's relatively straightforward using iterative algorithms to recover the suppressed values or ranges, narrow ranges on the suppressed values. And this can be done for two-dimensional or multi-dimensional tables. And the other thing is if you're releasing multiple tables with overlapping dimensions, so overlapping fields in your tables, it's quite possible to use that overlapping information to recover the small cells that you were trying to hide. So releasing tables requires a lot of skills if all you want to do is release tables. But it is essentially the same data set. This is a different representation of individual level data. So if possible, you would take the individual level data, apply the de-identification to that, and then create the tables from the individual level data. Create the tables from the individual level de-identified data, and that way you can address the disclosure concerns from the beginning, rather than try to create tables and then deal with issues around tables, which can become quite complex. The other question that sometimes comes up is whether the identification works, and there have been some statements made by members of the community around that. So I'm not going to discuss this in detail. I'll suffice it to say that based on the evidence that's available now, data sets that have been de-identified properly, there's no evidence that they can be re-identified. And so if you want to take an evidence-based approach that's informed by best available science as of today, if you de-identify the data properly, it's challenging to re-identify the individuals in those databases afterwards. And that's as far as we can tell, that's what the evidence says. So the advice is follow good practices for identification and you should be okay. And the alarmist messages around the easy re-identification are not supported by strong evidence. We published an article on this last year, which reviewed all the evidence. And the link is there, and you can read the piece and see what the existing evidence says around this issue. So I think doing the identification is still very important, and kind of from an overall risk management strategy perspective, it is very important to do so. Okay, so now I'll move on to talk about HIPAA specifically, and I'll talk about the two de-identification standards in HIPAA. HIPAA has safe harbor and the statistical method, so I'll cover each one of those in turn. And discuss issues around their interpretation, the interpretation of those of what they say. So safe harbor lists 18 elements that need to be removed from a data set. Some of them are direct identifiers and some of them are quasi-identifiers. So examples of direct identifiers are the names, telephone numbers, fax numbers, email addresses, social security numbers, and so on. And also you have what are traditionally considered quasi-identifiers. These are the zip codes, with some exceptions around those, and then all elements of dates except the year. So you're allowed to keep the year, but remove other elements of dates. And then, so there's a mixture of quasi-identifiers and direct identifiers. And if you remove that information, then the data set is considered de-identified according to safe harbor. And this was intended to be a simple, essentially cookie cutter approach for the for organizations to easily release data without requiring any sophisticated analysis in order to do so. So there are a number of problems with safe harbor, which I will cover now. But the first one, which has been well documented in the literature, is safe harbor removes important information. And the two important pieces of information that are being removed in many situations, especially when you're trying to do some kind of analytics on the data set, or for many research studies, is the removal of zip codes and dates. So a lot of studies need to know the dates or the temporal order or temporal relationship among events, and then for geospatial analysis, of course, zip codes are required. So the removal of those two pieces of information limits the amount of analysis that you can do. So essentially it reduces the utility of the data set in important ways for many types of analytics. But the problem doesn't stop there, because except under very specific conditions, which I will discuss, safe harbor data sets can still have a very high re-identification risk. So let's just go through the elements, some of the elements, to try to interpret them and understand what they mean. And I'll cover here the ones that have been, well, some more controversial, and also where more questions have been asked. So in terms of names, so safe harbor explicitly covers only the names of the individuals or of relatives, employers, or household members of the individuals in the list. So things like names of providers would not be considered as a part of the safe harbor list. So if you disclose a data set with provider names, it would be considered okay because they're not part of the set of individuals that are covered. So if your data set is patients, then the providers of the patients the names of providers of the patients would be allowed in the data set. For example, you need to remove names of individuals or their relatives or their employers or other household members of those individuals, but not their providers. And this has important implications. The other area of confusion is, what does element 18 say? So element 18 talks about any other unique identifying number, characteristic, or code, and also needs to be removed. So an example of a number would be a clinical record number. So this was explicitly mentioned in the in HIPAA, in the Federal Register, in the commentary around the regulations. Characteristic would be a rare and visible diagnosis. So there has been some work on identifying rare and visible diagnoses. We discussed some of that in a recent article on the Heritage Health Prize, where we considered rare and visible diagnosis when we were identifying that particular data set. But that would be a uniquely identifying characteristic, for example, and then a code would be a hashed social security number, which is an SSN that is hashed without a salt, or without a key or a randomness added to it. So that would be considered also a unique code, kind of an encoding. Hashing would be considered a form of encoding. So all of these will be removed from the data set in order to meet the requirements. The whole issue about codes for re-identification is also covered, and so this is the wording in the regs. So it says that a covered entity may assign a code to allow the identified information to be re-identified, provided that the code is not derived from or related to the information about the individual. And of course, then the second point is you apply appropriate security to that code, right? And so this is in a different section of the regulations, and the section that talks about the identification standards, but it's still talking about these codes. And codes have caused a lot of confusion over the years. One area of confusion is the inconsistency between how HIPAA deals with codes versus how the common rule deals with codes, and I will not talk about that here, but they are not consistent with each other, and this has been well documented. So in a research context, this has caused some additional confusion. And codes are useful for a number of things. One, if you want to track, of course, records for the same patient in a database. So for that purpose, you can just generate random numbers based on let's say, using a social security number. Then you can just create a unique random number for each SSN, and then that's not derived from it, and then you would assign that random number to each record, and that will allow you to track. The challenge comes if you want to, at some later point, re-identify those records, to assign an identity to the individual, either to notify them of an important result, or to contact them for some other purpose, or to link their records with some other database. As I showed you in the previous slide, any code that is derived from the original data is problematic. So a hash, of course, would be problematic because it's derived, but also a hash with a salt could be interpreted as problematic because it's also derived from the original value. So one possible way out is to use the second identification standard in HIPAA, which is the statistical method, which I will talk about momentarily. And if an expert can attest that the coding has a low re-identification probability, then that would be sufficient evidence that or that be defensible enough to allow you to use that kind of coding in the data set. So rather than rely on the safe harbor argument, you would rely on the expert attestation under the statistical standard to make that point. The other element of safe harbor is this point about actual knowledge, which says that the covered entity does not have, should not or must not have actual knowledge that the information could be used alone or in combination with other information to identify an individual. So what does actual knowledge mean? In a lot of presentations of Safe Harbor, only the 18 elements are presented, and there's no mention of actual knowledge. But actually, that's a very important caveat there. So actual knowledge does not mean that the covered entity needs to have knowledge of the literature and things that are possible, theoretically plausible, etc. It means real knowledge regarding their data set. So an example would be if it's known that the analyst has relatives in a database, then that creates a actual knowledge of potential re-identification risk. If you have famous people in the database where background information about these famous people is known, it can be used to launch an attack, or individuals with unique characteristics or occupations. So if you know that these kinds of individuals exist in your database, then it may be arguable that you have actual knowledge that the information can be used for re-identification if the data recipient, for example, under the first point, is related to someone in the database. So these are the examples of types of considerations that would need to be made to decide whether there's actual knowledge or not. Okay, so the problem with HIPAA Safe Harbor, as I mentioned before, is that it allows for a potentially high risk of re-identification. So a data set that meets the requirements for HIPAA can still have a high risk of re-identification. And this means that in general, Safe Harbor can be is applicable in narrow conditions where the data is a random sample from the population, which is a common assumption, so we're not going to quibble with that. Where the only quasi-identifiers in the data are the dates and zip codes. If you have any other quasi-identifiers, then you may not be providing sufficient protection if you follow Safe Harbor. And I'll give you some examples of that. The adversary does not know who's in the data set. This is a very important assumption, because if the adversary knows who's in the data set, then your risks can be very high. And then that the data is cross-sectional. It means that the data is not longitudinal data, because longitudinal data tends to have a very high risk of re-identification. Even if you have exactly the same variables as a cross-sectional data, if you have longitudinal information about the patients, the risk of re-identification can go up significantly. So we'll go through some examples here. First of all, inclusion of provider names makes it possible to determine additional information about the patients with a high probability, and because Safe Harbor allows the inclusion of provider names, it raises the risk somewhat, and by knowing the provider name, the facility where the treatment was received would potentially be knowable. If you know the facility, then one can argue that the patient will live at a reasonable distance from the facility, so you're kind of geographically narrowing down where the patient lives, even if you don't have more specific geographic information in other parts of the database. And then by knowing the specialty of the provider, you can also narrow down to the potentially diagnosis, or if you know the set of providers who the patient was seeing, then by knowing the set of providers, you can narrow down the diagnosis even further. So the knowing provider name can leak information that Safe Harbor was intending to protect, which is the location information, but also may leak additional information about diagnosis which may not be in the database. The other issue with Safe Harbor is that if we know that someone is in the database, the risk can be very high. So any kind of protection that Safe Harbor provides becomes really irrelevant. And here's a very simple example. So here's a 3-record data set. I'm releasing a data set with 3 records, and and this is consistent with Safe Harbor. There's only age in years and zip code. And then some information about a lab test that the patient had taken. So let's say this data set is released, and I know that Bob, my friend Bob Smith, is in this database. And I know that Bob is male, he's 24 years old, and he lives in zip code 134. So if I know that Bob is in the database, there's only one record in that database that matches. And it's record number 3, and I know the lab test that he's taken, which is indicative of a potential heart attack. So without this is a safe harbor compliant data set, and because I know that my target individual, the one I want to re-identify, is in that data set, everything else is irrelevant, right? The only thing that matters are the records in the data set, and if there's a unique record there that matches my background knowledge about Bob, I automatically know record number 3 belongs to Bob, and that's an identity disclosure. So an important assumption is the adversary cannot know who's in the database, which also means that to have any hope of being reasonably protected, these databases have to be random samples of some population where it's not known who's in the random sample that's being disclosed. Otherwise, you run into the risk demonstrated by the example I just gave you. Now, the other issue is longitudinal data. And Safe Harbor doesn't deal with longitudinal data, but as I mentioned before, longitudinal data may have a much higher risk, even for the same variables, than cross-sectional data. So here's a very simple example. This is from the State Inpatient Database for New York for the year 2007. So this includes about 2 million information about 2 million visits. It's a population registry, so barring some institutions that don't report and some data quality issues, but by and large, it's a population registry. So when we looked at the data longitudinally, so by looking at the pattern of visits of individuals, we created safe harbor compliant data sets on age, gender, and ZIP3 only. We found that 1.8% of the population in that data set was unique, right? Just on those 3 pieces of information. And the longitudinal component here was the zip code over time. So when a patient visits and has visit 1, they have a particular zip 3, and when they visit again and visit number 2, they have a different zip 3. So we're really just looking at movement over time, patient movement over time across multiple visits. And with just that information, 1.8% of the population of the patients is unique. If we add length of stay, then the risk is, so this should be age, gender, zip3, and length of stay. It jumps to 20.75% of the records of the patients are unique. So both of these are safe harbor compliant. In the second one, we added length of stay. So we still have the zip3 pattern over time, but we also have length of stay for each visit, and that dramatically increases the uniqueness in the population, right? And I'm using here uniqueness as the measure of risk. I'll talk about risk measures later on, but we've dramatically increased the risk of re-identification because the data set is longitudinal, and we've added this new variable which is not covered by safe harbor, which is length of stay. And again, length of stay is knowable information. The other factors with safe harbor and the difficulty in managing the risk with safe harbor data sets is that the risk of re-identification, at least some measures of risk of re-identification, are dependent on the subsample, how large your sample is. So for example, if I have a safe harbor data set, let's say it's a cross-sectional data set and it's 10% of the population, it will have a much lower risk than a 50% subsample of the population. So the 50% subsample may have a very high and unacceptably high risk, whereas a 10% subsample may have a low and acceptably low risk. And I'll show you here an example. This is the Pharmacy data set from one of the hospitals that we work with. So this is a hospital pharmacy data set. Each graph has been de-identified to a certain level of risk. So the first one on the right guarantees that the risk of re-identification is below 0.2, and the x-axis for each graph is subsampling. So in the first one, when you have an 80% sample, you have about like 17% or 0.17 risk, but then if you have a 10% subsample, it's about a 5% risk. So the subsampling has a huge impact on your risk. In this case, the risk is the percentage of this is the average re-identification or average probability of re-identification for records in the database. It jumps dramatically from a small subsample to a larger subsample, and because Safe Harbor doesn't take that into account, it's really hard to know what the actual risk is, unless the risk is very low for 100% of your of your data set, then any subsample will also be low. Unless that's the case, then you cannot guarantee that any larger sample will be large sample will have a higher risk, and lower samples, smaller samples will have lower risk. So you need to take into account the sampling fraction, which is something that's not taken into account in Safe Harbor. So you can't really know what the overall risk is of your data set. Not always, anyway. It's another challenge with Safe Harbor. So for these reasons, and there are a couple of other reasons as well, unless your conditions meet the assumptions of Safe Harbor, it's not really easy to know whether your re-identification risk is acceptably low or not. So if you have longitudinal data, or if you have more fields, more quasi-identifiers than Safe Harbor assumes, if you know who's in the database, if you have provider names and so on, all of these can make the risk run quite high, even if the data set meets the requirements of Safe Harbor. So this is why then, if the conditions are not met, you'd switch over to the statistical method. And I would argue that in most situations, in many situations, the conditions are not met. They're very hard conditions to meet. But if that's the case, then one should responsibly would want to move on to the statistical method. And this is the wording of the statistical method, which requires a person with appropriate knowledge and experience of principles of identification and re-identification to apply them to ensure that the risk is very small and document that method. So now we're going to talk about some of those specifics. So when you talk about documentation, the documentation part is very important because OCR may ask for that at a later date as part of their compliance checks. So it's important to document the method that was used, including the attack scenarios assumed for the data, the risk thresholds used and their justifications, the assumptions made about the adversary, and how re-identification risk was actually measured, and evidence of the validity of the metrics that were used. The other important question around the statistical method is who is an expert. So that's not defined in the regulations, but I think it's reasonable to say that expert would have the appropriate training or education on disclosure control methods, has applied them, has a lot of experience applying those methods in real-world scenarios on health data. So health data is different from other types of data. If one has applied them to, say, business data, or to even possibly social science data, the experience or the techniques and the issues that come up may not carry across easily. So experiences with health data, I would argue, would be very useful to establish this expertise. And of course, any kind of publications or evidence of knowledge in the area. There are some ongoing efforts now to develop certifications for these experts, or certification schemes for these de-identification experts, and I think you'll be hearing about those programs or schemes in the next few months. And we're also working on a training materials and program for de-identification experts, but I know that there are other organizations working on that as well. So hopefully this issue will be resolved basically soon. The other consideration is, if you read the Federal Register and the comments and responses to comments around the regulations, the measure of risk that's used very often in that documentation is uniqueness, which is essentially the percentage of individuals in the population who are unique on the variables or quasi-identifiers that we are looking at. And it's defined as percent of records in the population that are unique on the combination of quasi-identifier values. The main challenge with unique records is that they can be re-identified with certainty. So records that are not unique, where you have 2 records with exactly the same values, or 3 or 5 records with exactly the same values, there's some uncertainty about whether you've re-identified the correct record or not, you've done the correct match or not. If you have 2 records, then the probability of a correct match is 1/2. If you have 5, then it's 0.2, and so on. Whereas if you have a unique record, you have a match with certainty. The focus on uniqueness, however, while important, is not sufficient, because you can still get a very high re-identification risk even from the non-unique records. So, for example, we looked at the 2010 census, and we found that a data set that's strictly compliant with the Safe Harbor requirements will not have any unique records. across the whole U.S. or across any state. There are just no unique records in the 2010 census that meet for any data set that meets the safe harbor requirements. However, the average risk of re-identification due to the non-unique records is about 0.05%. This is across the whole country, but there are some states with quite high values. For example, North Dakota has a 0.241%, and Wyoming has 0.319%, and then of course the other states have values that are between I guess the lowest one is 0.03. But there's quite a bit of variation across the states in terms of the average number of individuals that would be re-identified if you try to match with the population. So this is if you meet the safe harbor requirements. But as another example, which another data set that does not necessarily meet the safe harbor requirements, we have a birth registry, for example, with 126,000 records, and we removed all the uniques. We applied the identification techniques to remove all uniques in the data set. But in that case, the average risk of re-identification was about 15%. In this case, we looked at the location. So this was a Canadian data set. We looked at postal codes, the date of birth of the baby, and the mother's age. So 3 quasi-identifiers. They were generalized to ensure that there are no uniques in the data set. So a data set without any uniques and only those 3 variables, still the average risk of identification was about 15%, so it's quite high. So that's the problem with uniqueness, is that it's a necessary but insufficient condition. You definitely want to make sure that you have no population uniques in your data set. But that's not sufficient to provide you with kind of overall assurances that the risk is low, because non-unique records can still have an unacceptably high risk of re-identification. So in terms of other ways of measuring risk, there are two that have been used quite extensively. One is to look at the maximum re-identification probability in your data set, and the other one is to look at the average re-identification probability. The maximum is assumes that the adversary is targeting a single individual and is always higher than the average risk. And this has some important implications in terms of how we conceptualize risk when we use the statistical method. This article, which appeared also last year, in the appendix of this article, there's an overview of a number of risk metrics and a kind of a formal definition of the risk metrics that evaluate identity disclosure risks, and it doesn't talk about estimators and so on, but describes the metrics that have been used, so the maximum risk, average risk, and various decision rules around those risk metrics as well. So here, if we just look at the universe of possible attacks on a data set, we have 2 dimensions. One is the top one is the nature of the adversary. These are the columns, and the rows are the attacks. So the first row is I'm giving you a database, and the recipient of the data is going to try to link that database with another registry to re-identify individuals. So this is essentially a linking attack. It could be a voter registration list, for example, or some other internal database. And then the second row is the adversary is trying to target an individual. So this could be a famous person or someone they know. They're trying to re-identify the record that belongs to that individual in the data set. So the rows describe 2 different types of attacks. One is matching with the database to try to re-identify everybody, and the other one is I'm trying to re-identify the record for a single individual. I know that individual, it's a famous person, it's my neighbor, and I want to find out which record in that database belongs to that target individual. And then on the columns, you have 3 types of adversaries. So the first 2 columns are where the recipient of the data set is known. So let's say I'm giving my database to a company, so I know who the recipient is. And with a known recipient, you really have to worry about 2 things. One is an internal adversary, so someone within the organization is going to try to re-identify the data, and or the organization has practices that may not be ideal, and there's a breach and the data is exposed publicly, or to some criminal elements, and they're going to try to re-identify the data. So really these are the 2 concerns of from an adversary perspective when you're giving data to a known recipient, or there's a public release. And because we, as I mentioned before, the rate identification, maximum rate identification is always higher than the average rate identification, that essentially eliminates the first row. Because if I manage the second row, I automatically manage the first row, just because of the nature of the metrics. If I manage the risk from rate identification of a targeted individual, so I manage my maximum risk, I automatically manage my average risk. So really then, when we're evaluating risk and trying to determine whether the rate identification risk is very small according to the statistical method, we look at those three. So if I'm giving data to a known recipient, I really have to worry about two T2 and T4 in that table, and if I'm releasing data publicly, then I worry about T6 only, right? So essentially it comes down to three types of attacks that we have to consider and evaluate the risks for. So the next important question to operationalize the statistical method is what is very small? As part of the regulations, the risk has to be very small. And there are really two ways to conceptualize very small. One is to measure very small in terms of the data set only. So I have a data set, and I want to determine whether the probability of identifying individuals in that data set is very small. Or you can look at the context, the overall context of the disclosure. So if I'm giving the data set to an organization, to a researcher that has very good practices in place, my overall risk goes down. The overall risk of rate identification goes down because the internal adversary scenario attack, as I mentioned to you, there are two: internal adversary or breach. Go back here. I have internal adversary or breach, T2 and T4. So if I'm giving data to a company, I would look at what are the chances of an internal adversary occurring, existing, and identifying the data, and that can be quantified. There are ways to actually measure this. And what's the probability of a breach occurring, and take that into account when we are evaluating our overall rate identification risk. So it's kind of a context-sensitive approach to evaluating the risk. In practice, the disclosure control community, the people who did this in practice, right, not the people who write about it, but people who actually do it, who've been releasing data for 20 years, have always taken a context-dependent approach. And if you look at the guidance material that's been produced by or national statistical agencies that have been disclosing data and large data custodians, they always took this context-sensitive approach, where they take into account who they're releasing the data to, what conditions and contracts are in place, and the sensitivity of the data, and so on. And therefore, in practice, you have to take into account the context in deciding what is very small risk. It's not based only on the data; it's based on the data and the context of the disclosure. So what that means is if I'm the same data set, if I'm releasing it to in two different ways under two different contexts, I may have two different definitions of what very small risk is, or what's acceptably very small risk is. Okay, so I think I've lost a couple of pictures in my slides, so maybe I'll just talk to it, and then the slides I'll send out will have the pictures in it. But essentially, so when we talk about very small, there's really a spectrum of risk values that one can use, and we've looked at the guidance and the literature that has been around for many years around this issue, and really the data sets have been released only under four definitions of what very small is. The uniqueness definition ensures that the risk is lower than 1. So definition of very small is any number below 1. But other values that have been used in terms of an acceptable maximum probability of re-identification have been 0.33, 0.2, 0.1, and 0.05. And these bins have been consistently used for the last 20 years, and that gives us some very strong precedence for understanding what very small means. And then choosing between these four different values, or 5 different values if you include the uniqueness one to it. Again, based on strong precedence, The kinds of things that have been taken into account are the security and privacy practices that are in place by the data recipient. So if a data recipient has really good data management and security and privacy practices in place, then you would reduce the overall risk of the transaction is low. Whereas if the data recipient has poor practices in place, then the risk is high. So this is how we can take into account context, and there are checklists for evaluating those things. And that by taking that, quantifying that context, then you can come up with you can choose one of these four thresholds with very strong precedents to meet the requirement of very small. So then the overall de-identification process that meets the statistical method essentially consists of setting the threshold based on this context-aware perspective, and then measure the actual risk. And as I mentioned before, we have three types of attacks. You choose the type of attack that is relevant in your situation, or the types that are relevant for your situation. You look at the maximum risk, because if you manage that, you manage the other ones. And you measure the risk you compare to your threshold, and if the risk is higher, then you transform the data and you apply the identification techniques to that. And if the risk is lower than your threshold, then you're good, and you can show that your risk is below the thresholds, and therefore you can argue that it's very small. And then in terms of transformation methods or ways to transform the data, again, from a very practical perspective, the methods that have been used are essentially suppression, generalization, where you reduce the precision of the data, and subsampling. And these have demonstrated over the years, many years of actual use, that they can still produce data sets with high utility if used properly and with appropriate trade-offs and balancing in place. That data sets with high utility can be produced by playing around with these three different sets of techniques to produce data sets that have risks below your threshold. Okay, and then we're coming to a close, but one important question that also comes up often is how long is the de-identification valid for once it's done? So we've done some work on this, some work we've done on the on registries with a very stable process. In this case, the example I'm using is birth. So birth registries, when we de-identified data sets in year one, and then applied the same de-identification on data set that came 5 years later, the de-identification was still good and effective. So de-identification seems to be valid for when the process and the data collection and the clinical context has not changed much, can be valid for a long time. So what we found is that the de-identification that we determined in year one was not optimal for year 5, but it still worked. So if we redid it in the third year, for second year, we may be able to come up with another de-identification that results in more data being released. However, the de-identification was still protective in subsequent years, which was very, very interesting. But in processes where the situation where the process is changing and where the business context is changing, maybe 5 years is too long. So generally, we recommend revisiting the issue every, say, year and a half, 2 years, and reevaluating the risk. No de-identification may be needed, but the risk may be useful to reevaluate the risk again. And I'll leave it at that. So hopefully I've covered sufficient elements of the two regs, identification standards in the privacy rule, the two parts of the regulations that cover the identification, and hopefully I've clarified some of the ambiguities or inconsistencies there. So the question box now has appeared. So we don't have a lot of time for questions. I do apologize, but I will stay for as long as questions are coming in. And if you have any questions, please type them in now, and I'll read them out for everybody and respond to them. And while we're waiting, well, here's the link to our website where you can get a lot more information. And as I mentioned, we've developed tools to operationalize a lot of these things. If you're interested in finding about those, drop me an email. And the slide deck will be posted online in the next couple of days, as well as a video recording, and you'll receive an email when all that material is posted online. The other thing that may be useful to mention is that OCR is expected to produce some guidance on the identification standards in HIPAA, and the expectation is that that guidance is going to come out soon, but it's not clear what soon means. Some optimists I know believe in the next couple of months there will be this guidance material will come out, but it's really that's not an official statement, but that's just an expectation. But when that guidance comes out, then I think it'll provide more clarity on how to interpret and apply the data identification standards to HIPAA in the HIPAA Privacy Rule. So if you have any questions, please type them in. We'll wait for a few minutes and see if anybody sends in any questions. Okay, there you go. Okay, so the first question is, how important are patient initials for this issue? Well, that's very interesting. Patient initials often come up in the context of clinical trials. A lot of clinical trials use initials and date of birth as as a unique identifier for the CRFs in the trial. And I don't know of any studies that looked at this explicitly. This is something that we're planning to investigate empirically, so we can have some data. But there are a number of ways to look at this. One is that within the context of a facility or a site, if the initial and date of birth were not uniquely identifying of patients, then they wouldn't be useful and they wouldn't serve their purpose, which is essentially to identify patients' records correctly when they come in for their visits. So with that argument, one would expect that the combination of initial and date of birth would be uniquely identifying within a facility, and therefore the risk of identification there would be high. Looked at from another way, initials and date of birth for a multi-site study or multi-center study across many sites instead of a single site, so where the individual site is not known, and you're simply using initials and date of birth as a unique identifier there, that's not known. The answer is I just don't know. Nobody has, as far as I know, nobody has done an empirical analysis on identifiability across multiple sites using initials and date of birth. Initials by themselves, again, there's no data. I don't know of any data that looked at initials by themselves, but I would imagine certain combinations would be less likely than others. But at this point, there's no publicly available analysis on this issue. So it's an interesting research question, I would say. And it keeps coming up in the context of trials, and it's unfortunate there's no data to help inform decisions about this.